Thank you very much, and I'm very pleased to be here. I am envious of those of you who shopped. I saw a Williams-Sonoma bag, and that's one of my favorite stores. So this topic is one that is a very important topic, and I think that there's a lot of myth and lore that goes on in between the lawyers and the doctors about what is appropriate, what are you supposed to do after an adverse event. And I've been practicing since '82, representing the Bay Area hospitals and UCSF since 1982. So a lot of my examples are from lots of different hospitals, not just UCSF. But these are real case examples. So I think what I want to start with is a reminder about the relationship between consent and disclosure, because it really is sometimes the flip side of the same coin. You can disclosure after something goes wrong. The quality of your informed consent can help with that disclosure. So remember that the conditions of participation for CMS, which I'm sure all of your facilities are taking care of Medicare patients, these are all of the requirements that we need to do for informed consent. The nature and purpose, the likelihood of benefits, complications and side effects, and the alternatives, and also problems during recuperation. So a thorough discussion of the treatment plan, what to expect, can help buffer the discussion if something happens during the procedure. So this is really, I just gave a version of this talk to our residents and fellows in their grand rounds, because what I'm trying to do at UCSF is change the culture of the organization in favor of appropriate and ethical disclosure. It is a big ship to turn around. Some of our physicians, a physician not so long ago said to me after an adverse event where I was helping him prepare for disclosure, how long have we had this policy to disclose? And it's been around for a long time. And I do think that people who are the defense attorneys, and that's what I used to be, but now as the director of risk management, may have a slightly different perspective on what disclosure means, and I'm going to try to bridge that gap. So why do we disclose? What is an adverse event? Tips, real practical tips. What's the difference between disclosure and condolences? Some case examples, and finally some do's and don'ts, and hopefully I'll be able to get this done in 38 minutes. So why do we disclose? In some states, including California, it is the law to disclose certain adverse events. And check out your state. In California, we have 27 nevers, which comes from the National Quality Forum, that are reportable to the state of California. And after these events, you have 5 days to report it to the state. And the statute says you must have disclosed the event to the patient by the time you disclose it to the state. So it's really important for wherever you work to know about those mandated disclosure statutes. And also it is ethically based. If you look at the AMA Code of Ethics on disclosure, it gives a very cogent discussion of it. And it ironically can help maintain the physician-patient relationship. We had a case not so long ago where we gave a person who was immunosuppressed a vaccination of a live vaccine, and the young person became blind. And we did not avoid a claim. We seriously injured someone. But the physician's response to the claim, to the adverse event, and his meeting with the family and meeting with the patient, I have never seen anything so extraordinary, and he is still that patient's physician. And I do truly believe that it helped us avoid such a level of anger, that it helped us settle the case at a reasonable level of compensation. So I do think it's very important to the physician-patient relationship, and it can avoid claims. It doesn't always if we have a serious injury. So patients do experience two types of disappointment: the disappointing unanticipated event, and that points back to the quality of your informed consent, and then the disappointing way the healthcare providers behave after the event, Research shows that patients are more forgiving of the former versus the latter. And I've seen that in the last 32 years of doing this work, sitting across a table from people taking their depositions and hearing how angry they are, not really understanding the medicine, but remembering vividly how they were treated after an adverse event. So what is an unanticipated outcome or an adverse event? There's lots of different ways to define it. A stab at defining it here would be a negative or unexpected result stemming from a test, medical judgment or treatment, surgery, or the failure to perform a test. It is not necessarily the result of medical error or professional negligence. So in my sort of non-techie way of trying to explain the two different kinds of origins of an adverse event, I've done it this way. On the left-hand side, you see an adverse event without error, and on the right with error. And it is really sometimes much more difficult to explain a complication than it is to explain and disclose a real simple error that is just without controversy as to what happened. And so, for example, a cardiac catheterization where there was a perforation of the heart, that's a complication. The patient has passed away. The family is saying, we need accountability here, and witnessing the physician do an excellent job of talking about the risks, benefits, and alternatives and what happened. But the family members, of course, were not present during the informed consent discussion of their loved one. So it's much harder in that situation to explain why we no longer have a patient or we have a seriously injured patient. So outcomes can come from lots of different places: unreasonable expectations, biological variability, although in litigation that's very hard to convince people of, low probability risks and side effects, wrong judgments without negligence, hardest thing to explain, and medical or systems errors. So to complicate matters, at the same time you have this disclosure. This is an example of a California jury instruction, and every state will have their own version of something like this, that the jury is instructed that a physician isn't necessarily negligent because he chooses one medically accepted way of doing something, and it turns out that another medically accepted method would have been a better choice. And this is the classic retrospectoscope, the Monday morning quarterbacking. I was on the phone with the father of a child who had serious cancer, and the physician elected not to remove the child's eye. He was trying to save his eye. The cancer progressed, the eye had to be removed, and he needed chemotherapy and might have avoided chemotherapy had the eye been removed. Of course, the dad thinks now the best way to have done this would have been to remove the eye, and trying to explain medical judgment, even though in hindsight it would have been better to remove the eye. It was reasonable to try to not remove the eye. That's hard to explain. And then, of course, success is not required. The legal system understands that medicine is not a perfect science, that if there was strict liability every time there was an adverse event, I doubt that any of you would be doing what you do. And the juries understand this, and I think our next speaker will talk about some of those issues. So let's get into a little bit of the practical sort of checklist of what you can do after an adverse event, and then we'll get into a few cases. So one of the first things to do is to talk about how the patient's care is going to be managed. We're dealing with what's going on currently with your loved one. Arrange for the appropriate consultants. Advise the family of a contact person. This is the biggest part. It sounds simple, but the biggest start of where things go wrong is that there's a discussion, people walk away from the discussion, and there's no plan for further discussion about the adverse event after we've been able to determine what happened and why. So it's very important to maintain that trust, or to try to hold on to that trust, just to arrange for someone to be the contact person. Of course, my perspective is to get risk management involved so we can preserve evidence. We had an error embolus case where the catheter came apart, and it was put in during the anesthesia in the ICU. The nurse was going in to change something, and it came apart, and air got in. We think we made a MedWatch report. I'll talk about this case in a little bit, but we didn't make. We then had a code, so we're not retaining this equipment. And now, of course, the product manufacturer is trying to use that as a way to get out of taking responsibility for the design of the product. Ensure follow-up. We're going to talk about why disclosure may be an ongoing process, and you all are trained to have the answer now. So disclosure isn't like taking an oral board. You don't have to have the answer right away. You talk about what you're going to do to get the answer if we can, and make sure you have that contact person. Document the event and the disclosure. Advise other staff and nurses of the plan for disclosure so that the message to the family and the patient can be consistent. This is, again, where I'm trying to move the dial at UCSF in changing the culture. The nurses, after something happens, are the ones that are always getting the questions because they're sometimes afraid. They're not going to talk to you. They're not going to talk to the surgeon. They're going to talk to the nurse, and they're going to be sometimes pretty snarly with the nurse and upset and angry. So what has to happen in an institution for a disclosure program to be successful is for everyone to believe and understand that there'll be an investigation and that our best understanding of the truth will be disclosed, and that please give us the opportunity to do that investigation. And the nurses, if they have confidence that disclosure will occur, we have to work with them to have the message to the family consistent. So, before the meeting, we're going to march down the road to a disclosure session. Decide the time and the place to disclose. Who should disclose? It is our policy that the attending is the primary person responsible for disclosure, not the resident. It doesn't always work that way. It's not a perfect world. Should the person who was at the sharp end of the air be the one to do the disclosure? I think it is very much of a case-by-case decision, and that there should be a process of deciding who is going to participate. If a resident made his or her first significant error that resulted in an adverse event, I would think you would want to think long and hard about the emotional trauma to that resident and whether he or she should sit in on the disclosure session. Sometimes it is therapeutic for them to sit in, sometimes it isn't. And that's why I think part of your process has to be a thoughtful discussion of how should it work in this case. Obtain permission from the patient to speak to the family as needed. And I've made a big mistake that way after a cardiac cath death where the patient was a woman, her husband was there, her father, who was from the Valley in California, was there, was very angry, and I said, "We will talk to you, Mr. Smith, about your daughter's death." By the time the disclosure session came around, there had been a split in the family. The daughter's father and mother were blaming the patient's husband for leaving her in the middle of the night, and of course the husband retained the right to decide who would hear the disclosure, and he said, the parents of this patient are not going to be in the room. I assumed, of course, something different, but you have to determine from the patient or the surrogate for the patient who's going to participate. And of course, consider the patient's and family's emotional state, the need for privacy. All too often, I see things going on in the hallways, discussions in the hallways. It's hard to know what those discussions are, but they should not be a disclosure session in the hallway. The meeting. These are all much easier said than done. Empathize and make eye contact and have an open posture. Hanging your head, putting your head between your knees, not making eye contact, all things that happen, becoming very defensive. These are things that happen. You try to counsel folks about this ahead of time, but it's hard and people are upset. Consider the health literacy of the patient or the family. Remember that you have to deconstruct what you do for the family. Some people, when they get under stress and they're trying to disclose, will go to a very technical disclosure, or they will go to a connect the dots disclosure. And I think you have to, if you're going to be ethical and truthful, you have to break it down and consider what the family will understand. And of course, verify the the family's understanding of what happened. At one time, I had a case where we overdosed a pulmonary hypertensive patient with Flolan, immediately killed him. We had a problem with our guardrails on the pump, and it was a nursing issue. It was one of those cases where there was absolutely no issue as to what caused the patient's death. But when we came into the disclosure session, the family focused on something entirely different. They thought something entirely different had happened. So, and confirm what they understand. And of course, discuss the objective information contained in the medical record. Don't discuss confidential information. So if there's an M&M, a root cause analysis, or something of that nature, the process of those deliberations in most states are confidential, because the legislatures have recognized that unless medicine has a safe haven to discuss adverse events without all of that being disclosed in a court of law or elsewhere, you just simply won't do it. So the process of reviewing cases is confidential in most states. The facts are not confidential. And of course, for goodness sakes, turn off your pager and phone. So this is also the sort of where I think we have myth and lore. The truth versus speculation, subjective information, confidential information, speculation, or blame. Now, in some institutions, sometimes there is a culture of conflicts between anesthesiology and some surgical departments. And we will get phone calls from anesthesiologists who think that I see some of you chortling there, and I would chortle myself if I weren't given a lecture. But I get calls from anesthesiologists very concerned that the surgeon is going to blame them for whatever happened. And I get more of those from anesthesia than I do from surgeons. It's an interesting phenomenon. So the patient is going to hang on to everything you say. And examples of things that have happened: this should never have happened, okay? Things like that have been said by social workers, surgeons, an orthopedic surgeon. I should have done blank, 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 where that person was beating himself up for the woulda, coulda, shoulda, and which is appropriate, but the family's going to understand that as an admission of liability, when in fact he is applying the retrospectoscope to himself, and the family isn't going to understand that. This happens all the time: trashing other providers, showing frustration with each other in front of the patient. You may have legitimate reasons to be frustrated with each other and your other colleagues, but the patients, we don't want to take it outside. We want you to take it outside. It's upsetting, it's confusing, we don't know what's going on. And of course, sometimes more in nursing than in medicine, playing the victim or the unempowered will be misunderstood. And a recent case involving a surgical site infection where the patient is alleging that the surgeon said, "This one's on us," when in fact we're hoping that it isn't. When should risk management participate in disclosure? Consider the hospital policy that requires reporting the events to risk management. We want to do an early investigation. We want to preserve evidence. We want to communicate with all the people, the leaders in the organization, and we sometimes will play in my organization, and this does differ from place to place depending on philosophy, it lets the family know that it just isn't the involved provider that knows about the event. And my colleague at UCLA would say, well, that means they're going to think you've got the pocketbook. And I haven't seen that in my experience, but it lets the family know that we take these matters seriously and that we're going to do a review of the case. And of course, we do help providers with disclosure, with preparing, because people are very nervous about it. We can help with how it should be documented, and we do participate in multidisciplinary complex cases. And I participated one where the ED, the surgeon and anesthesiologist, and then the post-operative care, all those folks were involved in a series of unfortunate events. And we were asked to kind of lead off the disclosure session. And I think that because of the issues in the case, had risk not been involved in that one, there probably wouldn't have been disclosure. So it just depends on the case. And of course, we do want to sit in my hospital on cases where there's significant damages or potential for a claim. And why do we do that? Because I want the physicians to stick with the medicine, because that's what you're doing. And if there are questions about the claims process, let risk help answer that question. Let your legal counsel help answer that question. Because physicians, I find, are pretty uncomfortable with going in that direction. And we can give them our card, we can arrange if they want to speak with us, we can do that. And that just keeps everybody doing what they're trained to do and where their level of expertise is. We also manage bill waivers or holds. In the hospital setting, sometimes we have a retained sponge, and we have a second surgery. Right out of the gate, we're going to hold the bill for that second surgery to go back in and get the sponge. We're not going to bill the patient for that. And risk manages that at our organization. Find out who does at yours, or get a process going for doing it. Documentation of the error should be objective. Again, no speculation, just the facts. Discuss the management and the treatment plan. No discussion in the medical record of the corrective action. The medical record is to record what is being done for this patient. What we're doing to change the pump that gave that Flolan, or the handoff between the residents that didn't see the patient post-operatively, or the way you position a patient to avoid an issue with something in the OR. Those are things that don't go on the record. The incident report, everyone in this room has an incident report system. I think it's across the country, but that, again, in most, if not all states, is a protected process, again, for the purpose of improving care. And it's protected. You can bleed all over the incident report, but not in the medical record. So the documentation of the disclosure can again vary, and if it's a significant one, we've recommended that you date and time it to people who were there, the details of the care, discuss future care, but the legal issues don't go in that documentation. Patients plan to make a claim. I mean, that isn't part of the medical record, that's outside of it. So here's a case I referenced earlier. Post-operative patient suffered an air embolism when the catheter tubing disconnected, and the catheter tubing had been put in the OR. There was an uncertainty as to cause, but the investigation concluded that there was a problem with the tubing and the locking mechanism. We switched out every single catheter of this tubing of this kind throughout the hospital, and I wish I could give you the name of it, but I'm not remembering it. We did a MedWatch report. How many of you are familiar with MedWatch? Okay, MedWatch is a program managed by the Food and Drug Administration that allows for providers, hospitals to file a report with the FDA about a concern about the design or safety of a device. And it is confidential. It cannot be used in litigation. We filed a MedWatch report for faulty equipment design, and the catheter set was completely changed, and that we interviewed the nurse, and her version was consistent that there were equipment issues. So the patient had an air embolus, had a significant injury from it, post-operatively. So this is the attending surgeon's note. The patient, unfortunately, developed an air embolus secondary to an inappropriate accessing of his cordis without appropriate consideration of the lock mechanism. The attending was very mad that this event had occurred. I don't blame the attending, but we are dealing with this note right now in litigation, and this is a UC case, I will disclose. The attending had not spoken to the nurse involved, had not been present at the time of the event, and had not participated in the investigation of the cause. And yes, this is Exhibit A in the case, and of course, it is the primary note trying to be used by the product manufacturer, who is a co-defendant with us, in trying to avoid liability. So the attending, I think, realized that what had been written was wrong, and said that in the deposition that she just gave. And in fact, it wasn't a cordis that was used. So that is helpful, and it's truthful, because once you put something like that in the record, if the investigation shows something different, you can never unring that bell. So what you think might be the truth may end up being wildly incorrect. And if you take away nothing else from this lecture today, I hope you will walk away with the understanding that disclosure is a disciplined process to determine our best understanding of the facts. Not your opinion about what happened, but what the investigation shows. And that is where I think a lot of folks will say, the attorneys will tell you not to disclose. What most attorneys are telling you to do is to not speculate, and to not just absolutely hamstring them in being able to demonstrate the truth. Another very large damages case with a patient undergoing surgery. Anesthesia was responsible for the positioning of the patient and the use of a bite block. The patient was face down in this surgery, and it was a very lengthy surgery. And during the course of this, where there were drapes all around the table, it wasn't the custom and practice to go crawl underneath the table and see if the bite block was there. The bite block had fallen out during this very lengthy procedure. The procedure was a procedure to remove tumors that affected all of the nerves and the facial nerves. And the opinion by the surgeon was that the deficit that the patient had was related to the bite block. Okay, anesthesia versus surgery. And of course, he was dead wrong. Dead wrong. And of course, what he didn't realize is that he's the captain of the ship, right? So even saying something like that is not going to get him off the hook for liability. But in fact, all of the examinations and everything about the case showed that exactly what happened with this patient was a risk of the procedure and not due to anyone's negligence. Hard to unring that bell. So, switching to the other part of this is, don't forget your needs. Don't forget the needs of your people if you are at a teaching institution, your residents. Seek help for your emotional needs, because the second victim programs are popping up all over the country, because when something bad happens, you guys are devastated. And even with residents who come in and talk to me after an adverse event, they've gotten A's their entire life. They are the best and the brightest. This is the first thing that's happened to them that's bad. And they may look calm, but I have learned to just assume they're not calm. I've become a bit maternalistic in trying to get them to our faculty and staff assistance program. Because you're going to have chaos, and you're going to have intrusive reflections, you're going to have the effort to restore your personal integrity, you're going to be enduring the inquisition, and I say that because I'm going to be asking questions. A lot of people are going to be going, what happened, and you have to get emotional first aid, and you can move on. I have seen people move on. I saw a resident who made a large error, and she was, I think, a first or second year. I just saw her not so long ago. She's the chief resident, and she has blossomed into a fabulous person, and she survived what she thought she wouldn't be able to survive. So the difference between condolences and disclosure, don't mix them up. Condolences are very different. People who express condolences are not always the people to do the disclosure. And of course, I would suggest in some residency programs want their residents to do letters of disclosure, letters of condolences, not disclosures. And of course, when we had what I'm about to show you happen, somebody suggested that risk review all letters of condolences, and I said, don't be ridiculous. We can't do that. You all have to give some guidelines. So my guidelines is to keep it personal, not medical. And here's an example of that. This is a note that came, we have to really figure out who are you doing the condolences for, yourself. Don't use the letter of condolences to meet your emotional needs. You need to get help elsewhere. And this case was a note that came back to us after the litigation during the deposition, and we hadn't seen it, but even though it was 2 or 3 pages long. And some people would say that, the plaintiffs tried to argue that this is an admission of liability, which we said it's not. It's silly to say that. But I think the resident realized that she was doing it for the wrong reason. So here's a case. We've all had transfers coming in, and even in the OB arena, this one is related to a AAA. A 54-year-old male presents to the ED of Hospital A, and Dr. Ima Begging from Hospital A calls his buddy, Dr. Soft Touch at Hospital B, who is in the OR in the middle of a case. Through a nurse, he accepts the patient. And based on representations from the hospital that the patient was awake and stable for transfer, the patient arrives 15 minutes later, intubated, with 2 physicians with him from Hospital A. Dr. Soft Touch is still in surgery. The patient is brought into the ICU and initially seen by Dr. Anesthesia, who is furious. He's furious that this communication took place without anybody, the transfer center, knowing, nothing like this. Dr. Anesthesia and another surgeon do what they can do to prep the patient and take him to the OR. The patient's eyes are fixed and dilated. And Dr. Anesthesia is confronted by the widow, asking for an explanation. Dr. Soft Touch, when he brings his patient up to the ICU, is again confronted. What do they say to the widow? So this case happened, and of course, I'm on pager 24/7, and I received, 8 or 10 pages on this that night and spoke to many of the people, including Dr. Anesthesia, Dr. Soft Touch, and they all truly believed that they had their version of the facts. In fact, I talked to Dr. Soft Touch about 8:30 that night, and I said, okay, well, I'm going to take what you're taking me and what you're telling me and talking to other people about it, and then we'll figure out what happened here. And he said, I'm just telling you what happened. I said, yeah, but it's like an auto accident. You've got your perspective because you're standing on the corner here, and somebody's standing on the block away. Somebody's comes up afterwards. It's everyone's version. They truly and truly believe that it's the truth, and we have to put it all together. And when the investigation was completed, none of the versions of the story were completely accurate. So premature disclosure about what happened in that case would have, to that widow who was very upset with the death of her husband, it was a Hail Mary transfer, would have made it much more difficult to manage the adverse event. A wrong med during labor and delivery, which was a clear error, and this was a young woman, and she received the wrong medication, and she had to have 3 doses of Narcan. She was very concerned about how it would have impacted her child. So what should the patient be told? I mean, again, some of these investigations don't take long. This one could be done very quickly. Who should participate in the disclosure? I think when it's a nursing issue, it needs to involve nursing. Should the nurse who made the error be involved in the disclosure? That depends on her emotional state. Sometimes if the person who made the mistake isn't there, the patient's family or the patient will vilify that individual. Instead, if that person is capable, and it could be therapeutic for them to be there to apologize, it makes people understand the humanness of it and that there's no intent to harm. But that's a case by case. So the risk reduction strategies, I have a sort of a changing, I'll talk about this in a minute. I think that depends on the case, and of course we don't turn over the root cause analysis document. So this is a patient who got the wrong echo, and that's as simple as it is. This is an example of a clear error, and here's an example of the way to talk to this patient about what happened. So, telling them that there were no worrisome findings, work with the appropriate staff, ask if there are questions. Another medication error where the patient experienced pain, the nurse inadvertently administered 2 mgs of Dilaudid, and the patient suffered a respiratory arrest, transferred for the ICU. The error was discovered within 2 hours, and the family is at bedside wondering what happened. So, a good way to think about it is to acknowledge that an event happened, to promise to investigate, and then to disclose the results and the implications. And this is from a gentleman, Dan O'Connell, who is in Seattle at the Healthcare Institute, teaches a lot about disclosure. So, here are some suggestions. An apology. He received more medication. We aren't sure how this happened, but we assure you that we're going to go do a thorough investigation. It may take several weeks. Sometimes you don't have that long before you're going to lose the trust of the patient. But this is certainly not the way to disclose. John made a mistake and administered an overdose. We don't know that. But if you say that, nothing else will be believed. So, should we allow the family to record the disclosure session? Okay? And I go around and I've just kind of relinquished the thought that I can control everything that happens in our 560-bed hospital. Folks are allowing these sessions to be recorded. The problem with that is that if we do not have a copy of the discussion, it could be altered, and we don't know what was said. So if you're going to have a policy, and I can understand why people want to disclose, want to record, have a process of, we'll record this session, but we'll each get a copy of the discussion. And that way we're on an even playing field as to what was said, because I've already seen many times, I've sat in on disclosure sessions that have ended up in litigation, and what's represented was said in litigation is nowhere near what was the reality. So part of me says recording might help here. What happens if multiple disciplines are involved? I think you need to have get to a best understanding of what happened in the case. And sometimes you might need someone to moderate that disclosure session. What if they want to bring their attorney? I don't think it's appropriate to have an attorney at a disclosure session. And some people would disagree with me on that, but I think that if that process needs to take place separately. And do we disclose every error, even if there is no harm? And this is the biggest question that we get all the time. And the defense attorney in me wants to say, oh, gosh, there was no harm, so there's no foul. So do we need to disclose? And I think it's a case-by-case basis. Sometimes we have our ethics committee weigh in if there was a med error with no consequence. I think it depends on the situation. But of course, the therapeutic privilege where we're not going to tell the family or the patient because it will upset them is not ethically sound. It's disfavored. But these are harder things to determine. So truth, transparency, teamwork, empathy, apology, accountability, management. This is sort of a way to think about disclosure. So here's a medication error, the follow-up. I want to meet with you again. I'm very sorry about what happened, so I could answer any questions you might have and tell you about our investigation and the changes we have made. I do think that in the red here, that sometimes families are satisfied, particularly if there isn't a significant damage, that we have done something to prevent a similar case in the future. And if we do settle cases, we will sometimes talk about what's happened, what changes have been made. We just settled a case a couple of weeks ago, post-operative paraplegia, where we talked to the parents of this young girl about what changes have been made. And they're never going to be happy, but at least they know that something came out of what happened to them. And of course, I've sort of changed my mind that defense attorneys will say, well, this is going to be used as an admission of liability. You change things. Well, it's a subsequent remedial repair, which most of the time is not admissible. But I think you have to balance that with what's the right thing to do. And that's where my perspective has changed since I've been in risk. So in summary, disclose errors if the error is confirmed. Have the attending physician lead the disclosure. Involve nursing as appropriate. Apologize. Now, apology is not admissible in California as an admission of liability unless you say something like, I apologize for being negligent. But when you say, I apologize that this has happened, that is not an admission of liability. Maintain the relationship with the patient. Inform them that there'll be an investigation. Help preserve evidence. And seek debriefing for yourself and your own medical team from an objective source, a chaplain or a palliative care social work, anyone that can help. Don't speculate. Don't deflect blame to others. Don't document emotion or blame in the medical record. Remember that surgeon who was so upset about the air embolus? Don't avoid the family or the patient. Don't project your own emotional response in the disclosure. So the final word here to walk out with, it's a disciplined process, and it takes institutional will. So best of luck to you, and I look forward to the Q&A session.